My name is Lillian Tom-Orme. I am the co-chair of the Native Research Network, and the National Native Health Research Training Initiative is a partnership between three organizations: the Indian Health Service, the American Indian Higher Education Consortium, and the Native Research Network. Instead of a national conference that we had planned in June, and due to the pandemic, we decided to do a series of webinars. And so this is the third, and we will be going monthly through November. And we'd like to thank you for joining us today, and we hope you'll join us the next few months. Today we have, I'll just quickly go through the agenda, and then we'll do our opening. We have speakers, starting with the keynote speaker, Dr. Dedra Buchwald. Will be followed by a panel discussion on institutional review boards, Dr. Alexandra King, Dr. Deborah Morton, Dr. Malcolm King. And then we will be doing an honor ceremony that Jerry Pardilla will be hosting, and for Dr. Felicia Hodge, who will be our final speaker. So with that, let me just quickly introduce who I am. I'm Dedra Buchwald, originally from the Four Corners area. My clans are Torhet Lini Do Nakadine Inslipit Ahni Bashashin, Kitachine Dashache, Do Tachine Dashanale, So for those of you who understood that, those are my four clans, and I welcome you to this afternoon's webinar. And so right now we'll turn the time over to Jerry Pardilla, who will do our opening blessing. Jerry is Penobscot, who has been involved in environmental protection and natural resources management throughout Indian country for many years. He's currently at the United South and Eastern Tribes, USET, as Director of the Environmental Resource Management. Jerry is former Penobscot tribal chief and has been involved in his tribal administration for a number of years. Jerry is also of Kiowa lineage, and so last year, about this time, he was inducted into the Kiowa Gord clan. And he's also a veteran, and he lives with his wife Marla in Rio Rancho. And Jerry sings traditional songs and dances, like I just mentioned. So we're very honored to have him do the opening blessing for us. Jerry?
Thank you, Lillian. It's an honor to join you today and to be part of this webinar series. I would like to share an opening song as my prayer form and give you just a little background. Many of you may not have ever heard of songs that come from the northeastern woodlands out to the Canadian Maritimes. We're Algonquin speakers, and we call our land Wabanowaki, the land of the dawn. We're on the eastern door of this big turtle island. And so we call ourselves Wabanoke. We are the people of the land of the dawn. And the song that I'm going to share with you is a very ancient one. My family have been songkeepers for generations, and I am in that tradition and carry on these songs and share those with my people. So the way that this opening prayer and ceremony would begin, if we were together, and if you can imagine in a time generations ago when we would be going about our daily lives, and there's an important occasion, an event that we would need to call the people together, that there would be a singer and a person who would go and begin to sing the song and travel in and around people's dwellings and calling them together for an important occasion. And this is what I will share with you, is an old welcoming song. It really is calling the people together. And this is in the tradition of my Wabanaki ancestors. Eliaha, 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 Eliakwanude, Eliaha, Eliakwanude, Eliaha, Eliakwanude, Eliaha, Eliakwanude, Eliaha, Eliakwanude, Eliaha, Eliakwanude, Egwanuda, Egwanudanaha, Egwanuda, Egwanudanaha, Egwanuda, Egwanudanuha, Egwanudaha, Egwanudanaha. Now that we've called each other together on this important occasion, coming from all quadrants of this great Turtle Island, I'm pleased to join you in this webinar today. Lillian?
I just got an unmute message. Can you hear me?
Yeah.
Oh, okay. So I just did a land acknowledgement. I don't know if you heard me. I'm in Utah right now, sitting on original land of the Northern Ute, Eastern Shoshone. So that's where I'm coming from. So our first speaker is Dr. Dedra Buchwald. Dedra is Director and Professor of the Institute for Research and Education to Advance Community Health at the Elson S. Floyd College of Medicine at the Washington State University. And her topic is small populations, big problems. So I'm just going to do very quick introductions. There's some beautiful bios that are posted on the website if you would go there and read them, because they do take time, and I want to make sure that the speakers have time to do their presentation. So right now we'll have Dedra start the discussion, and we all look forward to what she has to say about small populations and big problems. Dedra? Hello?
Can everyone see this? Hello?
Dedra, so far we can see you talking, but I can't see your screen, if that's what you're asking.
It is not showing my, Maggie, do you want to just show them? Because it's not showing my slides.
Yes, let me pull that up.
Just go ahead and do it. It's fine. Okay. Do you want to just make them full? So you, do you want to make them the full size, or, you know, from down here?
Yeah, is that not the full size?
I don't know. I can go ahead. Okay, I can just go ahead. So, Dankeschön. Es ist eine Ehre, hier zu sein und mit euch heute zu reden. So, I am German. My parents were immigrants from Germany. They came over after the war. My dad arrived on the shores of New York with 2 suitcases. And I grew up in the Midwest. I worked at University of Washington in the refugee health program, and that's where I met my husband, who some of you know, Spiro Manson. And that was the beginning of my journey with American Indian and Alaska Native Health. So next slide, please. So I'm going to give you just a little overview of our program first, and then I'll talk a little bit about small populations, big problems, and some of the approaches that we have taken, community-based approaches to try to address this issue of relatively small numbers, yet big problems across Indian country in a number of different areas. So we have a group called Partnerships for Native Health, and we do population and community-based research with partners that are American Indian and Alaska Native, and we've been doing that for about 28 years. We're a pretty big group. We have 67 people in our group. We are mostly people of color, and we have 35% that are American Indian and Alaska Native, and they are absolutely critical to doing the work. We have a pretty large research portfolio right now. We work both with urban and rural populations, all ages. And we also do research across a number of diverse areas, including physical and mental health, substance and alcohol abuse, which is what I'll talk a little bit about today, disease prevention and health services. And we do what we call translational research, which is basically turning a service need into research or vice versa, taking a research question and figuring out how that can bring value in terms of service to a community. We have 2 people who are dedicated just to reaching out on the ground, tribal liaisons and director of outreach. We do training and education, and I'll mention that briefly at the end. And we have a wide range of partnerships with tribes and urban Indian health programs, other universities, and so on. Next slide. Next slide, Maggie. Thank you. So you all may have seen a slide like this before, but I often get asked, why do you do community-based research? And the reason is that the illness is in the community. It's not in a medical center where many studies are done and we hear about bench to bedside. For every 1,000 people in a community, only 113 visit a primary care office, and less than 1 is actually hospitalized in an academic medical center. So if you want to know what's going on in terms of health, you need to do community-based research. Next. So as I mentioned, we do community-based health research. We have a wide range of topics. We try to respond to community requests as best we can, given funding opportunity announcements. And we try to link what we know are certain agencies or programs or tribes' interests with what we see as opportunities to bring resources to the communities. So you can see here, we really work in everything from cognitive impairment to alcohol dependence. Next. So I'm going to give you a few quick examples of projects. So this is one on colorectal cancer screening. We like to do projects that are easily implemented and that then can be translated into something that stays in the community. So in this study, we partnered with people at the South Central Foundation because Alaska Natives have the world's highest incidence of colon cancer. And this is basically a study where we randomize people to receive a text message or another form of electronic communication or usual care. And the goal was to figure out whether this pretty simple intervention would increase the number of people that got screened appropriately for colorectal cancer. So the intervention increased screening by 42% versus usual care in the typical age group that gets screened, that's 50 and over. So this turned out to be a very simple, cost-effective way to reduce morbidity and mortality. And we're now conducting the economic analysis for South Central Foundation at their request to figure out how much does this cost. Next. Another study we did is one that's on child and maternal health. And it deals with stressors that many Native families experience. This was another randomized controlled trial. We took an evidence-based intervention. It's a strength-based program. And it increases attachment between caregivers and parents and toddlers and infants. And this intervention has been shown to reduce downstream negative outcomes. So we conducted this project on 3 reservations. We trained up all local staff to administer it. It uses videos and individual feedback on parenting behaviors. We had 300 people and families enrolled with young children. And it showed a significant increase in parent-caregiver attachment. And now we're working with communities to integrate this into their WIC programs at their request. Next. We're doing a work on cognitive impairment. As many of you know, the number of Native elders is going to just explode. People over 85 will increase 7-fold in the next 40 years, so that's good news for Native communities. But these folks have risk factors. And we have done a lot of screening events. So for example, at a tribal elders luncheon, we screened 630 elders in 6 hours for cognitive impairment. And at another event, the NICOA event, we screened over 500 elders. They were so interested in knowing about their memory. And we found about 25% of those individuals had some impairment. So now we're going around Washington State. We're training primary care providers that serve American Indian Alaska Natives. We've made culturally informed materials. And then next slide. We're also engaging communities by reporting this material back to the tribes that we're participating. Next. So just before transitioning into the topic of small populations, big projects, I'll just mention one other set of projects. So we have an NIAAA funded alcohol center, and there are 3 projects on that part of this center. They're all randomized trials, and they are all very practically based. So the first one is testing the effectiveness of a culturally adapted, very low barrier community intervention that is called Native Choices. And the goal is to reduce the risk of alcohol exposed pregnancy in a couple of reservations in the Northern Plains. And those particular reservations have very high incidence of FASD. A second project is to test the effectiveness of an online motivational interviewing based sort of talking circle intervention to prevent harmful alcohol-related behaviors and morbidity. So it's essentially a harm reduction approach. And this is in urban Indians around the country. And the last one is looking at a navigator-based intervention to increase transition from detoxification, which is the acute treatment, to outpatient and residential alcohol treatment, which currently is only 1 or 2%. People just drop out. And this hopefully will prevent or delay readmission to detoxification and reduce the costs of recidivism. So these are all projects that are embedded in the community and that the communities are fully participating in. I don't have results because we're in the middle of these trials. Next. So small populations, big problems. The big question is, how can small populations address big pervasive problems like substance abuse? And when you look at it, except for a couple of the really big land-based tribes, most tribes are small. In Washington, which I'll use an example, we have 29 tribes, 27 have less than 5,000 tribal members, 13 have less than 1,000, and a handful have less than 250, small. So these small numbers hamper collecting precise, meaningful data that is needed to inform program development and health policies. And those numbers drive funding, and the national data does not reveal regional and local differences or impact. And I'll show you some interesting maps that speak to this. So many tribal communities are in a catch-22. They have anecdotal knowledge of local data, but the national statistics are of questionable local relevance to them. And most of the strategies before some of these that I'll present to you are basically developed by statisticians and have to do with manipulating the data or using different kinds of multivariate statistical techniques. Next. So talking about substance abuse, which I think we'll all agree is a big problem, here's some context. You probably know most of this, but the Native population is growing quickly. It's young. The median age, for example, of reservation dwellers is 26 versus 37 for the entire US. And substance use rates are actually pretty similar between Native people and non-Native adults. But American Indians tend to have greater lifelong use. One of the real problems is the adjusted drug overdose rates. And American Indians have had an enormous increase in the last 15 years. Over 500%. But what's hidden in those numbers is there is tremendous geographic and tribal variation, as you can see here, per 100,000 persons. So Oklahoma is half the rate of Minnesota, and Washington is sort of in the middle. You all know the Indian Health Service is dramatically underfunded. On the other hand, substance use disorders and problematic drinking interventions are a very high priority for the Indian Health Service. Next. So a little bit more context in terms of alcohol. American Indians are more likely than any other group to abstain from alcohol. They're also more likely to seek treatment, but they're more likely to drop out. No one really understands the high dropout rate, but it's possibly due to not offering treatment in their own communities and based on their culture. And culture is almost never considered part of evidence-based practices. And the bottom line is, and this has been acknowledged by SAMHSA, NIH, and others, that American Indian Alaska Natives lack accessible, feasible, culturally appropriate, and evidence-based programs. And those programs need to address a whole list of things: stigma, what do you define as recovery, abstinence-only philosophies, and all of the social consequences, the cost, whether medication-assisted treatments even work in these populations, and the known low acceptance of a strictly Western medical model. Next. So we've thought about this a lot, and we've come up with 3 ways to address this issue of being a small population. And the first, we actually did work with a statistician who met with people at a conference, and most of those people actually came from tribal communities or urban Indian health programs. And after a bit of discussion and a lot of hand-wringing, we came up with a way to think about borrowing data. And basically, borrowing data is using data from other tribal communities based on alignment of important constructs. We actually held a conference in 2009, and we brought 30 tribal leaders in, as well as others from organizations in 5 states. And they were invited to discuss what does it mean to share data? When would you be comfortable sharing data? And the overarching question was, what factors should researchers consider when grouping data from multiple tribes of different sizes? We conducted key informant interviews and focus groups, and we came up with 5 guiding criteria. And those are listed here: geographic proximity, community type, environmental exposures, access to resources and services, and economic development. And we wrote this all up. We took it back to the tribal leaders for verification. That resulted in 78 more pages of text. And we finally verified that these were actually the constructs that they felt were important. And this is important when you go to a tribe or a group and say, hey, here's a problem, but we're going to have to partner with other groups and other tribes. Bringing this kind of information forward is very useful. Next. Another solution is to develop a practice-based research network, which is 15 or more primary care practices that work together, and they're grounded in the clinical care that's provided at the community level. These kinds of research networks have done a lot of good around the country, and there's quite a few of them. Like, they've advanced the use of advanced directives, chronic disease self-management, and they basically deal with common healthcare concerns seen in primary care. Next. Here's another way that primary care has been affected by these networks. This is from one practice-based research network in LA. They developed this tool that automates patient assessments. It reads questions aloud to people. It integrates with the health records. It can send messages to patients. It can provide them with personalized health education and social services. And it's been used for behavioral health, substance abuse, diabetes, for all kinds of different conditions. Next. So we developed our own practice-based research network in Washington State. It's a partnership between my university and clinical sites to basically enhance healthcare. It's really focused on health equity and training health profession students on disparities. We're the only practice-based research network in the US to focus on recruiting tribal, rural, and underserved communities. Next. In our first meeting with faculty and leadership from my university and representatives from around the area, these are the things that they came up with as needing the attention of a practice-based research network. And you can see behavioral health, opioid addiction, chronic disease management. Those are all important clinical topics that they wanted addressed. So we've started to address these issues in the last year. We've submitted and gotten grants on suicide prevention in primary care, healthcare during the COVID-19 pandemic, and provider burnout. Next. And then what we do for all of our facilities, including all the tribal facilities, is we are working on providing an annual report for them on who they see, what the environment is in which they see their patients, and just sort of a comprehensive environmental scan, as well as information about their specific facility. And that's just a way of keeping them engaged. Next. So a third solution is Tribal Public Health Alliance. And this is something we're just starting to work on. We're proposing an alliance of the 29 tribes in our state, linked up with academics who have and want to work with Native communities to gather data on prevalence and treatment of behavioral health and addiction issues. And the backdrop here is that between 2013 and 2015, and that's the latest data I could find, the overdose rate in our state for American Indians, Alaska Natives is about 2.7 times higher for opioids and 4.1% higher for heroin compared to whites. So really quite elevated. And we're proposing a bi-directional approach that would merge both qualitative information, people's stories, and not only people's stories, but the anecdotal evidence that most of our tribal clinics have with quantitative data to try to understand what is working and why. And we hope to use this information to inform tribally driven strategies to develop and test these interventions. And you can see on the left, there's a small graph, again, illustrating the enormous disparity between drug-induced death rates in American Indian, Alaska Natives, and other populations in our state. And the kinds of things we can address are all of the ones that were outlined in the 2016 sort of really sentinel publication from the Surgeon General, Facing Addiction in America. We can look at promotion, prevention, treatment, recovery. The knowledge of all of our tribes. Next.
You like being carried around.
Some of the data that we are preparing to present shows why, excuse me, shows why small populations need their own data and why gathering small populations together can be important for addressing these questions. So these are some maps that use block level census data to look at various constructs around behavioral health and addiction. So this is the age-adjusted overdose mortality rate for 2015. Washington State had the 19th highest overdose mortality rate in the US, and that was about 15 per 100,000 persons. On reservations, it ranged from 0, because remember we have some tribes with 250 people, but more typically it was a much higher rate, and you can see that the highest was 84 per 100,000 people. And if you look at this map, some of our large reservations, like the Yakima Reservation on the lower half, excuse me, and the Colville Reservation on the eastern part of the state, what you can see is that even within a single reservation, you have different rates. So you have the orange, which is on the worst end, and then you have the different shades of green. On the other hand, on the left-hand side, you have a red triangle outlined in black. That's the Quinault Reservation. They're entirely red. So they have an extremely high rate. So we need this sort of data, not national data, and maybe not even reservation data, because even on a reservation, things can be very different and it needs to be addressed. Next. So this is another slide using GIS mapping technology. And basically what this shows is access to office-based buprenorphine treatment in 2019. And what it basically shows is that this type of medication-assisted treatment is just not available on reservations compared to national access figures. You can see the Western United States on the right-hand side, and you can see green is lower access, and then orange and red is higher access. And almost all the reservations have poor access, but even within reservations, things can be different on one side of the reservation to the other. And you can see the same thing in Washington State. Again, the Colville Reservation has widely varying access, and some reservations like the Quinault have uniformly bad access. Next. And this slide shows similar information on opioid treatment programs. Again, access is worse on reservations than compared to national access. Again, you see this variation between and across reservation-based communities, and it's always lower in rural areas or reservations that are more rural than some of our more suburban reservations. Next. And then lastly, this is the age-adjusted suicide mortality rate. Washington has the 22nd highest rate of suicide mortality, about 14 per 100,000 people. But on the reservations, it's more like 50 to 70 per 100,000 people. And again, you see variation across reservations, between reservations. So when you talk about the age-adjusted mortality in Washington state, you're really aggregating data in a way that doesn't inform small populations and local relevance. Next. And then this kind of aggregation of data can also help tribal communities figure out what they're doing really well. So this is a map of Yakima County, and it shows the treatment rate or lack of treatment for individuals with sexually transmitted infections. Gray is good, and you can see that gray and dark blue are the Yakima Reservation is outlined in black on the bottom there, and it's mostly gray and blue with a few splotches of red, which isn't very good. The rest of the county is, doing very poorly. So the rest of the county, is not an example, and these kind of data can be used to figure out what are the tribes doing right. Next. And then I just want to finish up by saying that in our work, training Native investigators and bringing American Indian Alaska Native people into the scientific endeavors is just absolutely crucial. And one of the things that we've done for, I guess it's about 28 years now, is a program called the Native Investigator Development Program. That's a 2-year program. And it's been funded by NIH since 1998. We've had 52 trainees, and those trainees over the years have brought in $200 million in grants. They've been on 500 manuscripts on Native health. 18 of them are now tenured. And I think the most important thing is that they have developed a web across the United States of individuals from 36 tribes, from multiple disciplines, who all have the same commitment, dedication, passion about bettering the health conditions of Native communities. And what you can see here is a social and network analysis of their manuscripts, which basically shows that these trainees across multiple cohorts, across multiple disciplines, across widespread geography, work together on projects. And it shows that it is a web of people that are trying to better the health of Native communities. Next. This is just a picture. We have a lot of fun. There's people probably that you can recognize there. And we've had some pretty notable graduates over the years. Next. So that's it. I'm happy to answer questions, and I really appreciate everybody's attention. And again, I'm honored to be able to speak to you today.
Thank you, Dedra. So Maggie, do we want to do questions at the end?
Yeah, we'll do questions at the end of the webinar session. If you want to type any questions you have into the chat box, and then I'll read them off.
Okay. All right. So we'll move right along. And so now we're going to have a panel discussion on institutional review boards. I think many of you know or have heard of institutional review boards that approve research that you do through the university, or if you're working with a tribal nation, they may have a formal IRB or maybe a small committee. We are finding that smaller tribes tend to maybe have approval through the leadership and various variations like that you'll find throughout the tribal people. What we want to do is, as you know, IRBs exist to protect research participants. And we wanted a discussion on how some of these individuals, the panelists that we have worked with both university level IRBs and tribal or indigenous communities. So we have three panelists. Dr. Alexandra King is an MD. She's a Nipissing First Nations member from the University of Saskatchewan. She's the inaugural chemical chair in Indigenous health, and her research is focused on HIV/AIDS, hepatitis, HIV and hepatitis co-infections. She is a principal investigator on various Canadian Institutes of Health Research grants. We also have Dr. Deborah Morton, who is an epidemiologist, assistant professor from California State University in San Marcos. Deborah teaches public health epidemiology and American Indian health and wellness. And since 2001, she's been involved in various American Indian research projects in California. She's founder and chair of the Indian Health Council, IRB. She's also co-investigator on their California NARCH program. She has a publication that we've, I think we're going to attach here, or maybe it's on the website, but it's called Creating Research Capacity Through a Tribally Based IRB. Was published through the American Journal of Public Health in 2013. So if you want to read a little more about that, we'll have that posted. And then finally, Dr. Malcolm King. Malcolm, I won't even try to pronounce the name of your First Nations. Dr. King is professor in the Department of Community Health and Epidemiology at the University of Saskatchewan. He's director of the Saskatchewan Center for Patient-Oriented Research, and between 2009 and 2016, he led the Canadian Institute of Health Research of Indigenous Peoples' Health as its scientific director. And this center, it's kind of like at our NIH level, is where they've established this Institute for Indigenous Health. Covers all the First Nations people, Métis and Inuit of Canada. So we have three very scholarly, interesting people to discuss IRB issues. So Marla Pardilla will help me ask some of these questions. And what we're going to do is we will each take turns asking you some questions. And so the first one, if you would just briefly describe your involvement with the IRB that you're working with, either at your university or with a tribal nation, just give us what your involvement has been.
So would you like me to do that? I could go first, and I just have a couple slides that talks about who we are.
Okay, great. So Deborah Morton will go first.
Can you see that okay?
Yes.
Okay, I can't, but hold on. I think I have to, no.
Can you do full screen?
Yes. Oh, let me get the full screen. Where is it? File. Oh, I'm not finding it.
Deborah, on
Yes.
the bottom right-hand corner,
Yeah.
a little thing that you can click on. So where your cursor is, if you move to the left a little bit, yeah, there you go. That should bring you to full screen.
Oh, there you go.
Yeah.
Okay, so mine seems to be underneath that one. And how do I go back? Let's see.
There you are.
It doesn't want to go back.
If you click on the slide, the blue slide.
Yeah.
There should be some arrows.
Yeah, it's not. Should be arrows on the slide. Okay, there we go. Thank you.
Sure.
Okay, so I'm going to talk about just who we are really quickly here. We are an IRB that was started in 2004 as part of the funding for the original NARCH project. So I work with a clinic in North County, in San Diego County in California. And we were, the clinic itself, in conjunction with 3 universities, was funded for research projects to begin back in 2001. So at that time, I think it was 2002 or so, I went to an IHS research conference, and IHS was promoting the idea that many tribes should create their own IRBs. So when I went back after that conference, and discussed it with the group and with the clinic, we decided that we would create an IRB because we were going to be doing a lot of research in the future. So we thought it might be a good thing to make sure that since the tribes would be working with universities, that they also had their own additional protection under the IRB rules that would come after the IRB approval by the universities from the researchers who wanted to do research there. Sorry. So so that's how it started, and we created an IRB that is connected to a clinic itself. And in California, I don't know if you know this or not, in California, we don't have IHS clinics. We have clinics that are owned and operated by tribal compacts. So our clinic has 9 tribes that own and operate the clinic. So it's connected to Indian Health Service with data and things like that, but it is it has its own board that runs the clinic, and all of those people represent the 9 tribes that are in the local area. So what generally happens is that it was kind of unique to have a clinic be the center of an IRB and be the center of research. So in some ways, it allows access to a larger population, as you said, small groups with large problems. So when you go through a clinic, you have access to a population that is made up of 9 tribes instead of 1 tribe at a time. So that's very researchers like that idea because they know their sample size will be bigger, and they only have to go through 1 IRB instead of going to a lot of tribal councils to get permission to do research in their community. So it works out pretty well. But however, clinics are generally, in California anyway, are generally not focused on research, they're focused on care. So this is a very unique clinic in the state of California, in the tribal community. And so researchers come to Indian Health Council they want to do their project with that tribe, with those tribes. So what we decided to do was create a specific IRB. And one of the first things that we have as a requirement that somebody who comes from the outside has to have an IRB approval from their own institution. So most of our projects have been with UC San Diego, San Diego State University, now Cal State San Marcos, and also with a private research institution, the Public the Pacific Institution of Research and Evaluation in Berkeley. So they all have to have their own institutional IRB approval before they can come to us. So that helps us to make sure that if this is a very complicated scientific project that we have no expertise in, so for instance, say a dental project, we had one of those, which was very biological. And so we know then if they have approval from their own university, that we won't have to worry about that part of their research. We know that's been approved. So then our IRB goes a little bit further and is more focused on the tribal community. Is this research going to be beneficial to the community? How will it benefit the communities? Is it respectful? And what will be the questions that they're asking? So that's generally what we do with our IRB. And we kind of, we are registered with the national or the federal Office of Human Subjects Protection. And what you have to have is a policy and procedures manual. And in that policy and procedures manual, you describe all of the organizational things that you have to do. And then we also have our 5 specialized requirements, which in addition to a traditional university IRB, which they don't require these things. These are things that we require that have always been specific to us. The scientist has to have a plan to return the data to the clinic so that there is a copy that's left there for future use. And then also with our informed consent forms, we require that they be read aloud to all the participants. So that then takes sometimes a very complicated and very scientifically worded informed consent form and translates it into a consent form that is understandable by the participants and then is also read aloud to them to make sure that they truly understand what the research project is going to be. Then the scientist group, they also have to have a plan to share their results. So besides a manuscript, so we have a meeting once a year. It's called the Scientific Advisory Board meeting. It's where the board members from the clinic, there's 18 of them, 2 of them from each tribe, and then the people from the clinic, staff from the clinic, and then all the scientists who've been conducting research throughout the year on the Indian Health Council tribal population gives a presentation on what they've done and what they have found. So, and then the tribal board can ask questions of all of those scientists to really understand what has been going on and what the research is and has been. And if it's not finished yet, what's going to happen next. And it's a very, very great exchange of scientists working with tribal people in that one meeting per year. So then we also required that we see their manuscript before they send it out for submission, and that we also see all of their conference presentations that they're going to do. Not their oral presentations, but their poster presentations. So we take a look at those before they go to the conference just to make sure that there's anonymity and confidentiality, because some of our tribes are very, very small. And so we're pretty paranoid about that. We also don't let them use tribal names, any specific tribal names. They refer to our clinic as the Southern Indian Health Clinic, Southern California Indian Health Clinic, which isn't the real name of the clinic. So, so that keeps the clinic population more confidential. So we look at their manuscripts, and some people have asked, is that a kind of something that we do, that we would take information out of there or try to, you know, kind of change their concept of their results. And that actually has never happened. We have only had a couple of manuscripts that have, that they have complained about the IRB that we took too long, and they put that in their manuscript, and we asked them to take that out. And that's the only time we have ever had to say anything about any manuscripts that have gone out for possible publication that we've asked them to change or to do anything with. So the whole process of going through the IRB at the beginning, before they can even go into the field, kind of takes care of a lot of issues that may have come up. For instance, we have issues sometimes with questionnaires, like, are these questions appropriate? Do they make sense? And everyone on the committee is a member of a local tribe or a community member or a staff member at the clinic, except for myself. So they know the clinic, the population very well. They know if those questions are going to work in the community. And then they also make suggestions. The IRB makes suggestions to the scientists about how they can make their questionnaire work better, and also how they can help with recruitment. So the fact that the IRB is made up of tribal members is very helpful to the scientists, especially if they're not familiar sometimes with the tribal population in this group of 9 tribes. So that's a really good process. And we also sometimes, occasionally, we haven't done it too many times, but we allow the PI to come in and give a presentation to the IRB if it's a complicated protocol, if there's a lot of consent forms, all those kinds of things. So, or we call them on the phone and we have a conversation with them, which is not what happens at the university at all. So those are the things that we do. And in this process of having these specific requirements, you know, this really encourages the community to become a part of the research program, because outside researchers could have problems recruiting their people, recruiting tribal people to be in a research study when they don't know that research scientist at all. They don't really understand what the research project is going to be doing. So our IRB committee, since they're all community members, they really, they understand more of what's going on and understand the research projects more thoroughly. And so then they can promote those projects to the community. So it actually, our IRB is very beneficial to the scientists in many ways, to help them get a responsive group of participants, to get a good number of participants, and then and those participants then have more trust in the actual science project. So when you do have an IRB, even if you start out with a tribal IRB and it's just for one tribe, it can have a lot of benefits both ways. Some of these, besides it promotes empowerment and trust, it also makes the research projects more compatible and more important and more usable to the tribal community, so they know what's going on. Also, funded projects, research projects, can provide jobs for people at the clinic or for people in the community. And through indirect costs, in this case, since it's a clinic, the indirect costs go from the funding of people at universities, because it's a NARCH project. Indirect costs go to the clinic, so that's extra revenue for them. Then it also promotes student involvement, so that we have lots of American Indian students at SDSU and CSUSM who participate in these research projects get jobs with these research projects, and then that benefits them. So all in all, having an IRB does promote capacity for research, even if for a tribe or for a clinic. So that's all I have for my presentation. And if you have questions, I'm happy to answer them. So.
Okay, thank you very much. Yeah, if you have any questions, please post them in the chat box and we will go through them at the end. So Drs. King, would you like to chime in and talk about your roles on the IRB, working with your First Nations and universities? And I know, Malcolm, you've had that very distinguished position at the national level in the Institute, and maybe you can talk a little bit about what you did there and how you've worked with the First Nations.
Okay, thank you very much. We might just first introduce ourselves. We're actually speaking to you from Frankfurt, Germany, so it's evening here, but we normally live in Saskatoon in Treaty 6 territory, homeland of the Métis in Saskatchewan. And we, as was mentioned, we're at the University of Saskatchewan. I'm Mississaugas of the Credit First Nation. My home territory is Toronto and neighboring areas in Southern Ontario.
And hi, everybody. My name is Alexandra King. I am a member of Nipissing First Nation, which is also in Ontario, about 4 hours north of Toronto. My Indigenous ancestry all comes from my mother's side. And we have Ojibwe from Nipissing, Algonquin from Temiskaming First Nation, and then also Mohawk from Oka. I know that some people have introduced their clans, and so I'm a member of Eagle Clan by birth and was adopted into Turtle Clan.
And I'm Crane Clan. So I wanted to talk about a couple of things. First of all, in Canada, we do have a good grounding for Indigenous ethics as part of our federal granting councils. That includes the Canadian Institutes of Health Research, and I had the privilege of being involved with the development of our guidelines for health research during my time with the national agency. The principles that Deborah talked about, we have a lot of those same ones in common, particularly the importance of benefits to the tribe, to the First Nation or Métis or Inuit group, the importance of giving back, bringing the results back to the community, and the importance of training and resources, leaving something for the community, for the betterment of the community as part of the research project. And so we could probably talk about that for a long time, but I wanted to talk about I think, quite unique Native Research Board that exists in Canada. It is at Blue Quills College, which started out its life as an Indian residential school in Canada. It's now a fully accredited degree granting college in Eastern Alberta that is run by 9 tribes, as you call them in the United States, 9 First Nations, mostly Cree and some Dene. They run their own college and they run their own IRB. And there's some unique aspects to to it. And again, in some ways, Deborah mentioned some of those. One of them is the importance of oral consent. Actually, many First Nations, Métis groups in Canada have developed alternatives to written consent. It's fully informed, and it's connected with whatever the local ceremony. In most cases, it's a tobacco offering. So we call it a tobacco protocol, where people who understand the significance of tobacco as a sacred herb are allowed to give their consent in that way. The Institutional Research Board, though, at Blue Quills goes well beyond this. They incorporate ceremony into their research ethics process. I've been involved as an applicant to them in the past, and I went there with my co-investigator, and we took part in a pipe ceremony, and that was the formal start of the research project. We had been granted permission to do research with the First Nations in that area, and the launching of the project was done with ceremony, with a pipe ceremony, really quite distinct from anything that happens in a university board. But the other thing, there's an evolution of ethics that's occurring. It's not static, even with our Tri-Council policy on ethics, it continuously evolves. And there's an important aspect, I think, that I see happening in Saskatchewan involving our university ethics boards. And that involves what are known as band council resolutions that take place amongst the political leadership on our First Nation reserves, or other similar things such as municipal council resolutions in organized Métis settlements, for example. These serve the purpose of research ethics review, and we've worked with our colleagues in First Nations or Métis settlements to make sure that the review that's done covers all the bases that are needed, things like informed consent, of bringing back to the community, of protection of data, ownership of data, for instance. And if a band council resolution, a resolution endorsed by chief and council on a reserve, or a municipal resolution for another type of community is done right, it can be taken to the university ethics research board and presented to them as this is the primary review of the project. And here are all the reasons why the project should be accepted, because all of the I's are dotted, the T's are crossed. And we've seen examples of how universities are now accepting things like well-crafted band council resolutions as the primary review. So I'm not sure if Alex wants to add something further.
So to, I guess, more directly answer your question, you were asking about IRBs with which we are involved. I do not serve on an institutional IRB, but rather as a researcher interact with the IRBs at our institution. University of Saskatchewan has a medical school, and we also have a very large agricultural science area. So we have both biological ethics review as well as a behavioral ethics. So just depending on the nature of your project, it would go to one or the other. Because I'm involved in research that sometimes is clinical, other times is more focused on Indigenous wellness, then I find that I am applying to both of these ethics boards, just depending on the individual project. So what I would say that we're seeing at institutions across Canada is that we do have these research ethics boards, and many of them are trying to work very hard with the Indigenous communities that they are serving, so in their respective areas, to provide a good ethical review on behalf of the institution. In terms of what unique Indigenous challenge have I observed, what I would say is that the institutional research ethics is fundamentally informed by Western philosophies and ethics. And therefore, Indigenous is an add-on rather than going back and foundationally talking about what would a research ethics review look like from an Indigenous perspective. And so when Malcolm was talking about Luke Wills College, that's a research ethics review process that has been built on Indigenous values and processes and so on. And so we're not seeing that at our different institutions. Now, in our country, there has been the Truth and Reconciliation Commission, which tabled their calls to action, and that was back in December 2015. And so all of our institutions are now trying to understand how do they go about implementing their calls to action. And some of this, in fact, includes the research ethic process. And so you're, as Malcolm says, you're seeing an evolution in what they're doing and how they're doing. So one of the things that I find as a researcher I'm trying to do is create space for our communities to be providing greater direction, having greater control over the ethics review process. And so as an example, we're working with one community, and it's about 6-7 hours away from the town where the university is located. And when I was speaking with the community, I was asking them, how do they see the research process unfolding for them? So I can explain how it works from a university perspective. There's, documents that I have to prepare and forms that I fill out, and it gets submitted and gets reviewed by the board. But from the community perspective, what would work for them? And so I put forward examples. Would you like to talk with the Research Ethics Board? Would you perhaps like them to come and visit community and see the lands on which the research will take place and meet some of the elders or community members and so on? And would you want to engage perhaps in a ceremony with the Research Ethics Board and, so on. So I'm not saying what should happen, but rather trying to create space. And so I will meet with the Research Ethics boards at my institution and put forward that perhaps these are going to be requests that will be coming your way. And I'm finding that the institutional IRBs are very open to these processes. So they are recognizing that we're on a journey, that ethics is evolving, and none of us really know where all is going to go, but recognize that we have to be on this journey together. So I see that as very positive. We're seeing increasing cultural responsiveness in our ethics and cultural safety. And so, and this means then that we're talking about things that are highly contextual to particular communities. And so I think that's probably what I would be adding at this point.
Yeah, thank you.
Okay, thank you. So we have a couple minutes left, and yeah, unfortunately, IRB issues we can discuss all day. You know, usually when we have a conference, we set aside a whole day to do this, and we're not really doing it justice by giving it, 30, 40 minutes. So I'm going to go to Marla Pardilla, have her ask her question, and I think that will be, take us to 1:20, and we'll have to switch over to the honor ceremony at that time. So Marla?
I wrote my question in the chat.
Okay.
Okay, basically the question was, how do we equip tribal and First Nations? Let's see. Okay.
Lillian, I can go ahead and read that question for you.
Okay, all right. Yeah, I was trying to find it.
There is a growing number of university researchers doing research on native lands. How can tribes equip themselves to better protect community members against unethical or unscrupulous research?
Create your own IRB.
Okay.
That's my advice, which is not hard to do.
I think from our perspective, one has to recognize ethics as a process. And so one is presenting the research, this is what we're intending on doing. And then as you are engaged in the research, sometimes the project doesn't unfold as expected. And therefore you have to be going back to IRB with amendments and so on. But I think that it's also very important that the community be involved with the changing process of the research. And ideally will be updating the IRB with their ongoing consent of that research then. And I think that's where that feedback, that loop is really important, that communities remain engaged in the research and engaged in the research process, ethics process, so that they're providing feedback. And some of that feedback may be that, in fact, there are things going on that we don't find ethical or have questions or concerns about. And at which point then I think the IRB needs to be stepping in and working with community to further investigate and understand.
Okay, thank you. Okay, so unfortunately our time is up. We had several questions and some having to deal with issues of traditional and Indian medicine, biological samples, DNA research, various things like that. So, I mean, like I said, we could go on and on all day and talk about these issues, how you deal with that coming through from the tribes or through IRBs, that sort of thing, how we do training. And that's something that our organization, the Native Research Network, has been doing in the past. And it's something that, we can probably pick up again. So anyway, so our time is up. Thank you very much, all three of you, for being available and sharing with us some very interesting things about IRB ethical issues. So thanks for your time. And now we'll switch over to an honor song, or let's see, that Jerry Pardilla will be doing. And our honoree is Dr. Felicia Hodge. She is a professor in the School of Nursing and Public Health at UCLA. She's been involved in research with American Indians throughout her academic career. She's been almost at all major universities, it seems like, in California, and went to the University of Minnesota at one time. And now she's back at UCLA, has done a variety of research, various topics, and we're honoring her by giving her the Dr. Frank C. Dukepoo Award We have a little write-up if you go to our website about who Frank Dukepoo was. But basically, he was a first Hopi geneticist. He was a biology professor. At the time of his passing, he was at the Northern Arizona University. He was born in First Mesa, Arizona. And there's just a really nice story about him, you know, if you look him up. And he's done a lot of work. He was very interested in albinism among Hopi as a geneticist. He wanted to try to find out, you know, what's going on with albinism, because there was a number of Hopi people who had this. Worked with the NIH Human Genome Diversity Project at that time, was just taken off. And he was just a very special person, very proud of the work he did with Native American students. He had about 2,000 students throughout both the US and parts of Canada that he was working with. Native students, really supported them and tried to get them to stay in school and then go on to college. And a month before he passed, I remember I walked with him from the hotel where we were all staying to go to the NIH campus to do some research grant reviews. And he told me all about his students, and he was so proud. And so anyway, so this award is named after Frank C. Dukepoo, and we are very honored to give this to Dr. Felicia Hodge. And so at this time, we'll call on Jerry Pardilla again to do an honor song. Jerry.
Thank you, Lillian. I'd like to share a song. It's a privilege to share this on this occasion with you, Dr. Felicia Hodge. The song that I'm going to share is a song from my people's present day Maine and the Canadian Maritimes. It's sung on important occasions and in intertribal gatherings and ceremonies to recognize achievements, honor community members, and was often sung in the installation of chiefs. So I sing a short rendition of this song today to honor your career achievements and dedication to healthcare and health research in Indian country. So this song is from a time when our people would be gathering and on an important occasion such as this. And I sing this song in honor of your achievements. Alehano kwanu de, alehano kwanu de, aleya kwanu de, aleha kwanu de, aleya heha, ale kwanu de, aleha kwanu de, aleya heha, ale kwanu de, aleha kwanu de, ale aheha, ale kwanu de. Chiwalewan, Chigwaha, Dr. Felicia Hodge, Debsil. Thank you very much. Pleased to share that song with you today.
Thank you.
So at this time, we're going to ask Felicia to give a presentation, and my screen isn't quite getting me to where I want to be. So anyway, like I said, there is a very lengthy bio documenting all the work Felicia has done on the website. And if you would go there and read that, that would be wonderful. And Felicia, would you like to step forward? And her topic will be the significance of behavioral factors in developing intervention research among American Indian Alaska Natives. Felicia?
Thank you so much. It's certainly a pleasure to be here with you today. I hope you can see the screen. Am I screen sharing?
Yes.
Oh, wonderful. Thank you. I am the one that is honored to be here today with you and to have the opportunity to work with tribes and to provide information that I think is most important to communities and to other researchers. I was reflecting back today a little bit about how I started to do my research, and I'm an enrolled Wailaki from Northern California. My mother's native, and she used to take me with her all around to Indian meetings when I was young, and especially when I was in high school when we got paid for some land up there. And I thought the process was so unfair. In fact, we were not able to have our own attorney at the table when the negotiations were happening. And the attorney the feds selected for the tribe actually elected to get up and sit on the other side of the table because I guess he was too afraid or ashamed to sit over on this side. So I had my mother come with me when I was in my 20s when I started doing research in the field because she had gone to Stewart Indian School as a young child and actually knew a lot of people in California. So I started my research in California, and I kind of wanted to go through 4 projects with you and to pull out some of the information that we have gathered to share with you in behavioral interventions. And so my intent is not so much to provide you with the various statistics that we have gathered, but rather to show how we have designed interventions and some of the findings that we have. The first is the Smoking Cessation Project. The very first grant I received in 1990, it was actually a UL one from the National Cancer Institute. We went to 13 sites, well, we went to 15 sites actually, but 13 sites ended up being a part of the project because they had enough participants in their clinic registry that we could draw on to random sample. So we did focus groups, we did a cross-sectional prevalence survey, and we did a random control trial to test an intervention to see if, what would work in helping people to stop smoking. What we identified was the age of initiation of smoking was between the ages of 10 and 13, and generally they start smoking because they were offered a cigarette by a relative, an auntie, a sister, an older brother, or something like that. So initiation started at home. We gathered information on psychosocial data on suicide attempts, ideation, and depression. We asked questions about abuse, and we tested the toolkit. And the message that people kind of voted on and agreed with was the message to quit for self, family, and tribe, that they didn't want just a message to say, I want to quit for myself because I want to be healthy or I want to live longer. It was more of your responsibility as a member of the community and the tribe. So I'll just show this once. This is the research design that we have used almost for all of our R01 projects. In the very first phase, we always use qualitative data. We always use focus groups and cross-sectional survey to better understand the situation, the terminology used, the communities that we are entering. When we do a randomized intervention, we do try to have at least an N of 200 with pre-test, post-test, and control groups. And we do an evaluation often with medical chart reviews, and our findings and all the materials are provided not only to the tribe, but to the control group so that they get all of the materials also at the same time. We started utilizing the talking circles in the early 1990s, and we adapted them to use in intervention studies. Our cervical cancer project used talking circle methods to have women talk about pap smear, cervical cancer, answer the questions they want to, with a goal at the end that they would get screening and what it would take to move them through those steps. We use talking circles as qualitative data methods, and more recently in focus groups. Then we moved on to storytelling methods. We use the storytelling with the cervical cancer and the breast cancer group to use traditional stories of women's strengths, of the importance of women to take care of themselves so that they can take care of the family and the community and future generations. We then started using storytelling methods and focus groups to allow patients and survivors to talk about their experience, their cancer experience, for instance, their smoking cessation experience, and if they were able to quit smoking. The California Wellness Project was a project that we had in the late 90s that went back to those 13 rural reservation sites to assess wellness. At that time, we got feedback from people that said, you know, why are we always looking at this negative? Let's look at something on wellness. We also got a lot of questions that let's look at men's health, not just women's health, but men's health. So we did a needs assessment at these 13 sites. We had an N of 457 who were recruited again from the Indian Clinic Registry of people who attended the clinic within the last 5 years, because we could always be assured that they were still in the area, residing in the area. We didn't want to get a lot of non-responses from people who were no longer there. So generally we recruit from the Indian Clinic Registry. And what did we find with regards to smokers? And I must say, before I get into this, when we went around and get the tribal resolutions of support, people would, the community and tribal leaders would say, well, what questions are you going to ask? So we would be prepared to hand out the questionnaires, and they would say yes on these questions, no on that, what have you. And several times we were requested to ask about abuse. And I was like, abuse? What kind of questions would you like? Well, you know, physical abuse and sexual abuse, all the way back to childhood. We want something on that. So we designed the questionnaire to ask, were you ever physically abused in childhood, adolescence, or adult? Were you sexually abused, physically abused? I'll go through all those. So what were our findings? We found current smokers reported experiencing physical and sexual abuse in their lifetime when you compared them to former or never smokers. Indeed, former and never smokers did not experience physical abuse in their childhood or adolescence. Surprise us. Whereas current and former smokers reported suicide ideation, and they reported they were more likely to drink alcohol. We also found that people who reported childhood abuse were more likely to fall in the area of overweight and obese, morbidly obese, as compared to normal weight and underweight. That's not unlike some of the general population data we had. We asked questions about poor wellness or being out of balance. And I won't go into it, but these are, I'll go into it a little later, but you can look at the slides later. I think some of these charts kind of is more telling that verbally abused, we asked, were you ever verbally abused in childhood? That was significant. Repeatedly neglected was significant. Physically abused was significant. Sexually abused was, even though we know only 1% of this group were males, only 1% of males had said they were sexually abused, and we know that males generally do not report sexual abuse, so we know that this is underreported. Abused as adolescents, not significant at all in any of the categories, whereas with adult, yes, verbal abuse was the highest. And so we asked the question and looked at abuse and suicide ideation in every one of these categories, whether you're a child, an adolescent, an adult, you were verbally abused, neglected, physically abused, or sexually abused. The significance with having suicide ideation was overwhelmingly significant, and that was a surprise to us. So if you look at predictors of adverse events, poor general health status was a predictor. Non-participation in cultural practices, suicide ideation was also a factor. When you look at predictors of wellness, cultural connectivity was strong, was significant, as was abuse in childhood and adult. So how did we measure connectiveness? We looked at identity. If you primarily identified as American Indian, had blood quantum as an American Indian, had relatives who were American Indian, that was one of the factors we used. Social support with nuclear family, extended family, employers, employees, and work environment. You participated in cultural events and ceremonies, and you could use a native language, either comfortable use, used at home, or somehow understood it. Then you fell in this this tool, this variable that we constructed to measure culturally connected. So we looked at, well, who was culturally connected and who felt that they were not, who was on the margins of these communities and didn't feel like they were connected culturally to their tribe or to their community. And we found several of these areas of abuse as being significant. I put together this little chart here and might do a paper on it. I've kind of been looking at it to find out what areas of connectiveness could we discuss as protective concepts. And I think as you develop an intervention, these are the things you want to look at in putting in an intervention and to measure. So I'm mindful of the time, so I do want to talk to you about one of these projects that is more recent, and I just truly enjoyed it. We went to the Southwest Arizona at 4 reservation sites and 3 urban sites, and we were testing an intervention to look at the management of cancer symptoms such as pain, depression, fatigue, and loss of function. We held 13 focus groups. I did 20 individual interviews, primarily of patients in the hospital, at their hospital bed. We recruited 184 adult cancer survivors, and many of them came with their caregivers to talk to us about the cancer experience and to test this cancer management toolkit. So we delivered it in a traditional talking circle versus a control site at 8 randomized reservation and urban sites. Our outcome measure was very simple. At pre and post-test differences, we wanted to look at, was your ability to manage cancer symptoms improved? What we found was, yes, it was significant that they were able to manage their cancer-related pain at post-test, and that an important factor was a close relationship with someone in the family or social support was instrumental in their ability to manage pain. Those were the 2 things. We also showed trending. The study showed improvement in the desire and the ability to improve cancer pain management. They wanted to know more. So we did some focus groups, and I will tell you, I'm publishing this paper, trying to get it together. So as we held some of the 13 focus groups out, one of the groups, we always had ink pens and papers, maybe colored ink pens out there. 10 of the participants, of the cancer survivors, actually drew their cancer pain on a piece of paper and submitted it to me, signed the back, dated it, and said, this is what it means. The first one said, pound, pound, pound. My cancer pain never stops. The other one was like, it is like lightning strikes, just every now and then, red hot, and it hurts. This other one on the left was cancer pain. It was a Hopi woman that said cancer pain just continues, just in all areas, in all, acute, chronic, little, big, it just never stops. And this last one, the woman wrote on the back, I have cervical cancer. My cancer has no color. It is like a black hole. There is no escape. Amazing. I had all of these, and they wanted me to share it with people, and I thought it was so interesting. So in thinking about developing a paper on this, I thought, is there a parallel to ledger art? Many of you know what ledger art is. When they were corralling American Indians on or near military posts is what it was. The military would send soldiers out into the field to track down Indians, shoot them. They would record the number of weapons taken out, checked out, how many bullets, and when people came back, how many bullets sent in, how many used, how many killed, all of that. So they recorded all of these events, these military events, and the staff person would write it out in ledger paper, just as if this is money. How many out, how many in, what happened. And if they made an error or something happened, maybe water spilled on me, coffee spilled on it, they may tear off this paper and throw it away. Well, American Indians at the post would pick up the discarded paper and would draw around the edges of it or would draw on the back of it. And what did they draw? They memorialized events such as their family, such as women healers. It's because of those that we know now that women were also healers. It wasn't just men. They would record family events, sisters, brothers. They also developed calendars so they could keep track of days and seasons of the year. All of these are on ledger art. They memorialize the event. And so I'm trying to draw a parallel to this artwork submitted by cancer survivors to memorialize their cancer event and their cancer pain. So at the end of the project, what were the barriers to pain management? It is so much. I sit around and think, it could be another paper, but this stuff is ongoing. It hasn't stopped. Communication between patient and providers are often strained. You know, some of the, especially the women would say, I'm in there with my husband or with my daughter's son. The doctor comes in, turns her back on us, is not talking to us, writes some things down, might say 1 or 2 words and leave. They're not sensitive. They're not sensitive to women's health, anything. You know, we're surprised. However, these cancer survivors say they have the utmost respect for providers, for nurses. Most respectful. They said they would never do anything to shame providers. They would never do anything to correct them. Even if they had the name wrong, even if there was something, they would not shame them by correcting them. They thought that cancer maybe was a new disease. It's not, but it's new in the language. There is no native words for it. However, I have collected a Hopi name for it and an Apache name for cancer. So it is now coming within the language terms to call cancer. Now, many of the patients that I talked to, we talked to a lot of patients, said they had a fear of addiction. They did not know how to control their pain, but they were adverse to taking a lot of medication. They just really thought the minute they take it, they're going to be addicted. So they either give meds away or something. Indeed, once I pulled up to the Phoenix Indian Medical Center for a session, and I saw an elderly woman walking out across the parking lot to get into her car. Kids were helping her in the car, and the brown bag went to the teenage boys, looked like teenage boys, and it was a full brown bag. And I thought, well, what is this? So I went in to meet with who I was supposed to meet with, who was the pharmacist. And I said, you know, how did you disperse the medication? This is what I saw. And she said, oh, yeah, you know, Oxycontin, we give 12 months of it in a paper sack for them to take home so they won't have to come back once a month. I said, you know what I just saw? I just saw kids taking it. You're giving it to people who are afraid to take it, don't take the medication, it's passing on to the kids. Well, that stopped, which I'm glad about. But it's of really concern, some of these processes that happened. When I interviewed the 20 cancer patients in the hospital, one man, he was Navajo, he came in to see me, and I was in the, I was behind the pharmacy office at the clinic, and he came in there very respectful, sat down and took his baseball cap off, and he had no hair. And it took him a long time to look at me, and he introduced himself, where he's from, who he is. I introduced myself, and he finally said, they took my hair. I said, what happened? And he said, you know, after seeing the doctor and coming in for these sessions for a while, I was taking a shower and my hair was falling out in clumps. No one told me that this would happen. I realized that this was as painful, or maybe more painful, than the cancer diagnosis. He said he lost his identity. He can't go out into the community. He has no hair. He hides it behind a baseball cap. He said he's lost his role within the community with his family. I know with many tribes, a death in the family, people cut their hair. If it's a close member of the family, they cut their hair even more. Hair has identity that a lot of the medical providers don't know about, don't discuss, and often they don't have good communication with the patients. At another session, I asked to talk to somebody who was undergoing treatment, and a Navajo woman was undergoing treatment, very friendly, and she said, yeah, come in here. And she was sitting in a chair and had IV in her arm, and I said, oh, you're getting medication? And she said, oh, yes, And I said, do you know what it is? Oh, no, And I said, well, do you have cancer? Do you know what kind? Oh. So I went over to the nurse and I said, you know, has she been told she has cancer? They don't remember. And I said, well, you know, what happened? She said, yeah, she has breast cancer. She's undergone chemo. I said, don't worry about her. Well, this patient had no idea of what was going into her body. No one even talked to her about anything. And one of the nurses who was Native said that they weren't supposed to carry on a long conversation with these patients. So I don't know who's going to talk and give education to some of these patients coming in. So let me switch back to the focus groups. Participants were telling us it may be taboo to even say the word cancer, that you bring it on. Said some of our elders say you bring on cancer if you say the word cancer. Certainly a lot of people feel that you don't say the name of the person who passed, you call them back and you need to leave them. Now I was going to show in this presentation the picture of the gentleman who talked about his hair and the woman. I have their pictures, they signed waivers. I did not have time to follow up, and I did not want to show their pictures if I was not able to get their follow-up response for that. But all in all, what participants were saying to us when we'd say, well, what about this experience? We don't talk about it. Did you talk to your mother, your family? We don't talk about those things. We don't talk about that. That's not something we bring home. So we started to talk about some of the terminology they were using is, we don't bring our burdens home. There's so much trauma there. We don't talk about it. We're not. Well, then who helps take care of these patients then? They need transportation. They need assistance around the home. They are traumatized. And if they don't get any help at all, this is really of concern. So these are new paper. One just, we don't talk about, we don't talk about it, I guess, is the latest paper that just got published. And if any of you are interested in this data or paper, let me know. I'll be happy to send to you. The last project is a recent one, and it's out there at Apache, San Carlos Apache in Arizona. Environmental justice, which is a new area we're getting into, means that all groups have equal protection and equal risk to environmental wellness and contamination. Unfortunately, that is not the case on American Indian reservations. A lot of people don't know this. In 1969 through the 70s, the federal government sprayed a mixture of dioxin, also called Agent Orange, along the Gila River in Arizona and across the reservation on houses and schools. Barrels of this substance were also buried outside of people's houses. Along the airport runway, was stored, I think, for almost 20 years in the basement of the daycare, since removed. This defoliant program was aimed to control tree growth along the river to ensure towns such as Los Angeles and Phoenix to get the water that they need because they're getting bigger. Bureau of Indian Affairs and the U.S. Geological Services engaged in this study as spraying this herbicide. It is carcinogenic, okay? The purpose of the program was to kill the trees. That was falsely, they now understand it doesn't reduce the water flow from the Gila River. The water still flows. These trees didn't suck up that much water. In 2018, the EPA showed the presence of these herbicides in the soil, but it did not examine the health impact of their exposures to tribal members. Since then, there's been reports of increased incidence of cancer, type 2 diabetes, and other problems. So the project that we are funded for, and we have an R21 and an R01 in on this, but we did receive a small bit of money from UCLA to interview the elders who experienced direct or indirect spraying when they were young kids in the 60s and 70s. These elders are saying they went out into the schoolyard to see what was being sprayed. Now, they used airplanes to spray, and generally they mix the dioxin with water. However, 105-degree heat, the water is going to dissipate. And so they mixed it with gasoline. Ergo, the elders said, well, we went out to the schoolyard to play and rainbows were falling from the sky. So they got this mixture on their skin, on their hair. It was all over the township. The federal government did not tell the tribe, did not tell anyone for the longest time. I think it was only maybe 15 years ago that they started, people are seeing reports and saying, what was that? Did you spray on us? Indian youth were gathered up, given shovels, told to bury these around. So they buried them around the houses. They buried them all over the place. We want to interview some of the elders who were used to find out, were they told where to bury them? Were they selected? Did they use protective gear? I doubt it. So the elders want to tell their stories. So overall, our studies that we have done over these many years have shown that predictors of adverse events were poor health status, low participation in cultural practices, suicide ideation, and there was certainly a significant correlate of the suicide ideation with adverse experience in childhood, adolescents, and adults is very severe. And we want to emphasize that protective factors were the concept of connectiveness, defined as identity, social ties, participation in Native events, and use of Native language is a strong protective factor associated with good wellness. Social support is also needed, strong social support. And culturally sensitive interventions that utilize constructs such as connectiveness is certainly needed. Stats are fine. I can give you all the data, the stats you want, but we need to understand how to develop interventions with tribes that will be accepted, that can be adapted, can be used and developed within these communities. And so I think that the trajectory of the research has found some of these very, very important factors. And I thank you for giving the time today for me to share the research. I certainly, am blessed to be able to do the work that I love, which is these research with the various tribes across the United States. And I thank you.
Well, thank you very much, Felicia. We give you a virtual applause and standing ovation and for your lifetime achievement. We certainly enjoyed your presentation, and thanks for doing all that wonderful work. I'm sure the tribes you've worked with appreciate the work you've done. Thank you very much.
Thank you.
Yes, so thank you. So we're at the end. I just want to make a couple of announcements before I turn the time over to Maggie to ask some questions. We have 3 more webinars coming up: September 16, October 21st, November 18th. There is a registration process. I know that it's a little difficult at times to register, but be persistent. You will eventually get in and register. And also we will be sending you, if you have registered, we'll be sending you an evaluation. We want to hear from you. And it's also posted on our website. So now I'm going to ask Maggie to ask some questions of the speakers.
Hi, everyone. Thank you all for joining today. We don't have much time left, and we want to be considerate of your time. So we're just going to ask just a few brief questions. If you have more questions, please email me. You can go to our website. I'm the contact. It'll email me directly. Otherwise, it's mgrandon, MGRANDON, @ahec.org. If you email me questions, I will make sure to reach out to the right person and get you connected and get those answers for you. So I wanted to start with Dr. Buchwald. What is the impact that COVID-19 has on suicide?
She has to unmute.
Dr. Buchwald. And it does actually look like she responded in our comments. So for those who don't have those pulled up, or if you've called in, she did actually comment, we don't know yet about the impact of COVID-19 on suicide rates due to a lag in reporting and misclassification as well. So again, if you have more questions for her, please reach out to me and I will definitely get those to her. For our IRB panel, we had a number of questions.
Maggie, I was here. I just had muted myself.
Oh, okay. So yeah, if you want to add anything else.
To the suicide COVID?
Mhm.
No, I just don't think we know. We certainly know that COVID has had major impacts on mental health and also on behavioral health and addictions treatment, but how that translates into, actual depression, other complications, and then suicidality, we don't really know at this point. There's just too many reporting lags.
Thank you. So moving on to our IRB panel presenters, did tribal PIs or tribal clinics work on the non-native side to build capacities, competencies, policies, do trainings, etc., so they were ready for doing our academic work this way? And if Deborah Morton is available, or...
Could you repeat that question? I'm not sure I understood the question.
Of course. Did tribal PIs or tribal clinics work on the non-native side to build capacities, competencies, trainings, etc., so they were ready for doing academic work this way?
Well, we have some native scientists, but who are doing research projects now at Indian Health Council. One of them's on HIV, one of them is on opioid use, but they got their training before they did any kind of research. So to have a tribal IRB, to influence younger people to go on and get training in research, we don't really have much to do with that. Our NNHRTI project does, though. Our NNHRTI project has a student component, which does encourage Native American students to get a graduate education so they can conduct research. And they've been pretty successful. We've got a lot of people who have gone through the program, gotten PhDs, a couple who are physicians, and lots of people with graduate degrees in public health. So.
All right.
That's all I know.
Thank you. Thank you. I think that is it for our questions today. We are at the end of our time that we've allotted to this. I'm going to turn it back over to Lillian for just our wrap up. And thank you all again. And again, if you do have additional questions, and I do see that there are some more in the chats, we'll reach out to the appropriate presenter and get those answers for you.
Maggie, you disabled my video, I think quite a while ago.
Uh-oh. Okay, well, thank you everybody for attending this webinar, and thanks for your participation. The webinar has been recorded and it'll be made available, and please join us for the next one, which is September 16th. Thank you, have a good day, and stay healthy and safe.
Thank you all.